Okay, welcome back. Today I want to talk a little bit about medication-assisted treatment, MAT. For those that don't know what MAT is, which is about everybody, medication-assisted treatment is that thing we call treatment for addicts. It's not exactly that at all. Medication-assisted treatment is one of the most gratifying things I do. What is it? Well, it's where somebody comes in and they're surrendering. They need help. They want help. They say, I have been taking pills, I've been injecting, I've been exposed to opioids, I need to get off. So rarely do I see somebody come in and it's just opioids. You've got to look at that big picture, that large differential diagnosis. And we got to think medically. So we say, throughout the history, physical and medical decision making, are we doing the right thing for the right reason? Is this a right person for medication-assisted treatment? And what I mean by that is this the right person for an opioid substitute? Well, what are you doing? You're just substituting one drug for another. No, you're not. Buprenorphine is the drug that we use here. Of course, there's methadone at methadone clinics. They're very heavily regulated. They're tough clinics on folks because they have to show up every day. It's very onerous and it's costly. Whereas buprenorphine, Suboxone, the evil Subutex, which is Suboxone without naloxone in it, to be discussed, or other meds like naltrexone, which block opioids, are introduced to the right person that is ready for change. Addiction is a brain disease, really misunderstood, and you have to have a no judgment zone if you're going to be involved in this game. No judgment mean it's not a moral failure. It's somebody that got into something from either a genetic predisposition or an exposure from circumstances, life's events. And I mean, it could be something as simple as breaking your leg and you just getting a bunch of oxycodone over time, and now you want more oxycodone when it's past time. And there it is. And there it is, because it's everywhere. This stuff is everywhere. There's an opioid crisis out there. It's really a fentanyl heroin crisis, but it's there, and the pills are there if you want them. So people come into us and they say, I can't afford this $15, $20 a pill regimen I'm taking from who knows who on the street. And let's face it, sometimes you don't know what you're getting. Vis-a-vis Prince. Prince didn't know those little pills he was taking actually were fentanyl from China. So the story goes. We'll never know the real story on that, but it didn't help him. Well, what happens when you hit rock bottom? Rock bottom to some people is 6 feet under. God rest Prince's soul. I don't want any other souls on my watch to be there. So medication-assisted treatment is that individual is ready to surrender. Where'd that term come from? Well, 12-step. Does 12-step work? You know, it goes back to the 30s. Treating alcoholics, it was a doctor, and it was an MD, and another guy, and they were drinking too much, and they surrendered. Basically, they surrendered. And to a higher being or to whatever. It's not clearly defined, it shouldn't be. But when somebody's ready to surrender, they say, Uncle, I've had enough, help me. They've usually heard about Suboxone. They've usually heard about some of these other meds, Subutex. All right, so here's a footnote on Subutex. It needs to go away. Suboxone has naloxone in it, or Narcan. So does the other commercial formulation that goes by commercial name Subsolve. It has naloxone in it. Subsolve's more of a pill form. Suboxone's a strip. Subutex is a pill, but Subutex does not have naloxone in it. Why would we do that? Well, if you cut or crush Suboxone and try to adulterate Suboxone/Subutex, you can snort Subutex, you can inject Subutex. It's a front row seat, and there you got another problem. People don't equate a drug that we treat addicts with addiction. Well, in fact, buprenorphine's the third most abused drug currently out on the street. Wait a minute, my doctor gives me buprenorphine for pain control. Right. Patches, trade name Butrans, really, really cool. They work great for pain. Other forms of buprenorphine you can put in your mouth as strips and the like, but they're micrograms. They're just a fraction. I'm not getting into math, but they're a fraction of what we use for addiction, because in addiction we use milligrams. So we can do great pain control with buprenorphine in a pretty low concentration or dose. When we treat the folks that need help from addiction, we up our game. And we use milligram, and it comes in different milligram strengths. And if it's slash something, it's got naloxone attached to it. Subutex does not. It needs to go away. Suboxone and Zubsolv, trade names, yeah, great drugs. You are not substituting one drug for another. It turns people's lives around. Suboxone is always one of those things you have to monitor carefully. You have to do drug screens, you have to do strip counts, pill counts, whatever it takes to keep this process of adherence monitoring, or monitoring the right use of this drug for the right reasons. And you have folks come in and their lives turn around. They get jobs, they're doing more, they're interacting with families. So what did I do today? Okay, what did I do today? So I saw a patient right in the beginning of the day whom I've been monitoring very carefully. She's a complete success story. 37 years old, mother of two. She had them young. She is in school. She's hitting the dean's list. One of her sons was selected to attend full ride an Ivy League school, and her daughter's right on his heels. Her husband works full time. She grew up rough in an abusive relationship from father who has since turned it around, and a mother that we haven't had discussions about. Comes in today with abdominal pain. Now, I've gone back and forth with her because she is such a good compliant patient who wants to be on this medication called Suboxone so that she can continue expanding her career and expanding her family and personal life to the best possible degree she can, and she's doing it. Abdominal pain. And so she ended up in the operating room, and she had one of her ovaries that was torsioned, and they had to take it out. It was an emergent surgery, real legitimate pain. So it's an issue when somebody is on Suboxone that binds very tightly to the receptor where regular pain medicines work. Those are called pure mu opioid agonists. The receptor is called mu. And buprenorphine, which is a partial agonist but binds very tightly, we have to kind of overwhelm that receptor or do other things. But she did really well with surgery, but had persistent abdominal pain post-surgically. Worked with her. I actually had to put her back on pain medicine, but we watched her and she did great with it, used it appropriately. We got her back on Suboxone, pain came back. Went back to the GYN, and it was kind of sad because the surgeon that did the original surgery had left. So she kind of was starting to fall through the cracks, got her back on track. Here she is this morning. Okay, I had her come in because her abdominal pain was up. And you do not want people finding a self-rescue. You don't want that. She's not the type, but you always have to remain vigilant. Sometimes people just get desperate, but she did great. She came in, her blood pressure sky high. What's going on? Okay, this is a typical thing we see. 15-minute appointment, what would you do? Now, this is what I did. Blood pressure sky high. Tried 2 different cuffs. Tried a manual, tried a electronic one. The electronic one we have is pretty good. It's operating room quality. One arm, the other arm, still high. Mind you, she's 37. She looks a little anxious. Yeah, she has some situational anxiety. She's anxious to go to her GYN, which the appointment's in an hour. She's underdosed a little on Suboxone. So what happened was she brought her pills in and she brought her Suboxone in. She took a pain pill, but the Suboxone probably wore off, so I gave her half a strip of Suboxone, came down. Was that exactly what I should do? I think so. But her blood pressure came down, she was less anxious. We put her in a quiet room, it's a special room we have. Pretty much recovered her, and her watch a movie because we have TVs in there. And like, it's a good room for what we used it for. And she was much improved. And she left understanding that we're going to have to communicate with their GYN so we can get her to the operating room and get her through her next surgery for retained remnants. That's what it was. And we're going to have post-op pain control and get her back on that Suboxone. Suboxone is a real option. Suboxone is not a moral failing. Suboxone is a wonderful option for people like this individual. It's life-altering, it's life-changing. It's not another drug for another drug. All right, so that was this morning. That's a patient that I thought made a point. She made a point that she had a real problem. I don't think she was really blown off, but care was delayed for a number of reasons. Now we're on track. We'll get her through this episode and off to recovery. So remember, recovery is one of those things you have to surrender to, and it's not something that's necessarily short term. Sometimes it's lifelong. How long are you going to be on Suboxone? I never really put a timeline on that. We shall see. Congratulations to this young lady, though. Fantastic job.